I'm Tony Sklar with bnetTV. We are here at the mHealth Summit in Washington, D.C. for 2012. I am speaking with Mr. Samir Damani from MD Revolution. How are you today, sir?
Very good, very good. Thank you for having me.
I had to reread the card in the middle of that there. So,
okay.
Listen, for all the people out there in bnetTV land, why don't you give us a brief overview of MD Revolution and exactly what you're doing here at the mHealth Summit?
Sure. So, what I was asked to do is I was asked to deliver a super session on the disconnect between mobile health and mobile technology. And what that disconnect is what essentially where MD Revolution fills the void. So the solutions that we're presenting for the problems of healthcare are siloed solutions. You have Fitbits that are being used in isolation. You have Withings scales that, sync to another app. You have, heart rate monitors that are available. All these things have great impact on precision-based workouts and lifestyle changes that are so critical to the reduction in chronic disease in this country, which are largely preventable. The problem is that they're siloed. They're not being brought together in a model that can be delivered that makes sense to the patient and engages the patient. And so what MD Revolution has done is we've built a clinical lab where we're taking these tools and the focus of the practice is actually the mobile health space. We have a mobile health bar, and where the IT person shows you how to use these devices, and we monitor, and so we measure, monitor, and motivate. And that's the paradigm we use. And the reason why we built the lab is because last year I gave the clinical perspectives on mHealth. And at that time I saw that there was really a disconnect between the ability to take the technology solutions that are available and actually deliver the one thing that matters, and that's outcome. So what MD Revolution is we've put together the process on how it engages patients, how to use it, how to use remote monitoring. We've had, in fact, at the conference, I've had my staff work with about 10 of our patients over the last 2 days on helping fix their zones, giving them feedback on the nutrition data that came through some of the apps onto our software. So we're able to kind of now understand how this process is going to work. We had 41 consecutive people that we've done statistical analysis on. We've seen, and I've never seen this before. I am also a practicing cardiologist in a regular model, and what we've seen is really tremendous. We've seen statistically significant differences in VO2, which is cardiorespiratory fitness, resting metabolism increases. We've seen body fat and visceral fat reductions in 41 consecutive people on a statistical significant level, which you don't usually see in such small numbers. The drug company sponsor studies are 10,000, 20,000,
right,
because there's such small differences.
Absolutely.
So what we're seeing is dramatic changes by engaging people through these technologies. And until we continue to build these models and show that the outcomes can be driven, we're going to be at a state of flux, right? And so we need to push that forward. We need to show how this is going to come together. And so we've also, we're on a search for a software system that could really bring it together and support a practice like ours. And we couldn't find one, so we built it. So we released our prototype here. We're featured in the Qualcomm release. It's called Rev Up, Health Accelerator, rev up your metabolism, rev up your fitness. And what that's doing, it allows the patient or and I say patient in a way that's very different, because our delivery model is now being looked at in retail settings. So we are talking to the Grove in Beverly Hills about using our services in their system. They're going to be offering our services to their loyalty program, and so we think there's a real role for this being in the retail market because of the cost containment pressures, and there's just not enough doctors to deliver this stuff.
Okay, that makes sense.
So in essence, what MD Revolution is about, we're about systematically integrating genomic mobile health technologies into a model that can be scaled.
So it's when I speak with physicians that are into technology, it's always fantastic because their ideas generally exceed their expectations in the beginning because of the amount of time that it takes to get it from here and into the actual working model of technology. Now, you said that you did a test or a trial of 41 individuals to get the statistical data to be able to look at. Does that mean that you're thinking of this in terms of like an FDA clinical trial where you're going to go to the next set that's going to be larger and larger and larger, but where's the critical mass come from? Where's the adoption? Where's the scale? Because everything that you're saying, I don't think that there are a lot of people on this floor that are going to disagree with you, and somebody needs to bridge the gap between physicians and technology. Mm-hmm. And it seems like you're on that track.
That's right.
However, critical mass is going to be key.
Right. So we've had over 200 people actually through the program. We just took the last 41.
Okay.
Because as anyone knows, when you run a business, the processes evolve and innovate and get better. So I'm happy to say in the 2 years that we've been doing this, the last 6 months is when we're really starting to see we can deliver this. So we've gotten several corporate contracts. We are in talks with Qualcomm right now about doing a pilot with them on corporate wellness. We are really looking to scale in 2013 to a much larger. I anticipate by this year, next time we'll have outcomes on over 1,000 people.
Okay.
But we've had over 200 already. We just looked at the outcomes on the last 41 consecutive.
Okay.
For that reason. So the scale is actually there. And I'll be honest with you, I also see patients in another model. I see over 150 patients a month. And I'm able to manage this because our model consists of a IT person, a nutritionist, a health coach, and a personal trainer.
But when you're in the hospital and you're visiting over 100 patients, 150
No,
patients
I don't have an outpatient practice.
Okay. When you're at your other job,
yes,
and you're seeing those patients are after the fact. They've already come to an event. That's why
a lot of them are.
Okay, a lot of them are.
A lot of them are.
Either they've come to an event and there is a critical point, or you're monitoring something that has happened.
Right.
So what you're talking about is it's reactive. So what you're
care.
doing now is you're saying, look at all we can do to prevent.
Yes.
Right? So
Yes.
I guess that's where I'm talking about that critical mass, that scale that needs to happen to see the reduction in pre-event.
Right. Well, that's why we use the visceral fat. If you look at the data on visceral fat and fitness, I'll tell you, if you take Lipitor, it had $13 billion in sales.
Right.
Okay? If you look at the absolute risk reduction, there's a concept in medicine known as absolute risk reduction, which is basically looking at the percentage decrease in somebody with high cholesterol that never had an event, that you put them on Lipitor, and somebody with high cholesterol that has never had an event, and you don't put them on, and you compare the two.
Right.
What do you think the difference is between those two groups when you actually follow them down the road to see whether there's a difference in outcomes? 1%.
1%.
So your number needed to treat for Lipitor to prevent one event, and this is not death. This is one event. This is an event, not
Correct.
death. Death is the best outcome, but we don't even.
Well, it's the cheapest outcome.
The pharma companies don't even look at that.
Absolutely.
Right. So what they found is that it's 100 people. You need to treat 100 people to prevent one heart attack. Yet we think in medicine, Lipitor is all we can do.
Okay.
Right. But if you look at VO2 in fitness, what's the number needed to treat? 6.
Okay.
To prevent death.
To prevent death.
So if you look at in the Journal American College of Cardiology in 2011 in May, there's a study looking at a single measurement of fitness in middle age and what it did to correlate with death.
You are not going to turn around America and say everybody's going to stop eating what they're eating and everybody's going to start to get healthy. You have to have a sense of digitizing the data to incorporate into the lifestyle.
That's right.
So that people can say, hey, I can see that something.
If you measure it,
I gotta stand off a little bit here, right?
Yeah.
Things are going north a little bit,
Yes.
and I don't want to have an event, or they're going to ignore it and say, I don't care.
Well, the reality is that, more is not better. So I get triathletes that come in too.
Okay.
And we're not all just focused on prevention. We have people with diabetes.
Okay.
I had a type 2 diabetic using our heart rate monitor and our programs that actually in 4 weeks came back. He went from 224 pounds to 230 pounds. He actually put on weight in our program.
Okay.
But it turned out he put on 16 pounds of muscle.
Okay.
And he lost over 20 pounds of visceral fat. So with muscle comes water.
Yep.
So weight's not a key performance metric on us, but visceral fat drives cancer. It drives heart. It goes over and over again. The Journal of American Medical Association had a paper on dysfunctional adiposity. That it's the fat around your organs that drives so much of the insulin resistant stuff we see.
Right.
So the idea is that, what I'm getting at, the reason I'm coming back to this, you're talking about the scale, the market.
Absolutely.
The market, the scale is that the reality is that if you just do simple things, like get 7,000 steps a day and somebody's monitoring it, somebody can tell you, hey, listen, this is what you need to do. It's actually remarkably easy to get these outcomes, which is why we've been able to get tremendous outcomes in 41 people. You don't usually see that kind of statistical significance.
That's fair.
In these many categories.
Okay.
So the scale is taking, if you can measure it, you can manage it. And people automatically start changing behavior if you can you don't need to get them to change anything. You get them to measure it. Get them to measure.
So education is key.
Measure. It's about measuring. Just measure. If you measure things, you and yourself you're gonna personalize it. If you're measuring everything you're doing in your life, and you don't have to measure everything, but you just we get people to log their food 2 days a week. 2 days a week causes dramatic changes because all of a sudden we now tell them, you had this, you know what, you could have just had this instead. My nutritionist does it. Because now through their API, it goes to our dashboard. You actually get 30,000 steps in a week. we actually send you a text message because our dashboard gets an alert, say you only got 30,000 steps.
What about the economic impact or the economic divide that you would inevitably have to get through, right? What you're saying is that, okay, you're going to have to purchase something, get something, do something that is may have an economic impact.
Costs money.
It costs money. Thanks very much. Thanks very
money.
much. It costs money.
Yeah.
How are you going to get people to spend money
Well,
on something?
we've gotten 200 people to do it.
Okay.
And you know,
how much money are they spending?
They're spending $895, but
Okay.
that includes the setup of the devices. It
Okay.
includes a 3-month access to the process. It
Okay.
includes 3 exercise sessions where you use a heart rate monitor.
Okay.
It includes access to the dashboard. But we're going to a subscription-based
$1,000
model.
is a lot of money for people.
You know what? It's interesting you say that because you go to gyms and people spend
So you're
way
correct.
more.
Absolutely, they do. Okay.
And so
But
people
there
are using
people-
this as a replacement to the gym because
So that's fair.
they can do it. They can do it on their own. So we actually are taking a lot of people away from gyms, and we're actually now talking to gyms about using our technology.
Well, they may be scared at that point. They're going to be losing membership.
Right.
They're going to have to
Well,
incorporate
they
it into their
actually-
membership plans.
But it also has a flip thing. If they embrace this, this is considered. Listen, if you are not using a heart rate monitor when you exercise, you are not getting the benefit. Because you don't really understand. Precision is so important. The reason why our outcomes, I'm going to go back to our outcomes, are so powerful is not because they're working and doing it. It's because they are now just being more precise with what they're doing. They're measuring their ownership. They now are engaged. They feel like they're in control. And
Okay.
it's powerful. And I encourage you to go to our website. We have a white paper on this, and we also have testimonials of very, very influential people, but then also the regular person who comes in, who is, you know, the person that's socioeconomically slightly challenged, and we get people of all spectrums, and we're actually going now with the software to a monthly subscription model.
Okay.
So for $30 a month, you can actually get the services.
Okay.
And so for $30 a month, which is cheaper than most gyms.
Yes, it is.
You get access to our software where you get to see what your steps are. You get to see what your weight change was. You get to see your LabCorp data, your hemoglobin A1C, your glucose levels, your other cholesterol levels, your inflammation levels. You get to see your genetic tests.
Empowering people
Empowering.
it's an amazing thing on what ends up happening.
It's
when
behavioral
you,
science.
It really is.
It's behavioral, and the thing about doctors,
You're
we
becoming a
don't
little
get
bit more of
trained.
a sociologist than
We
you
are.
are a cardiologist.
We are, absolutely, absolutely. I think that behavioral science is the most impactful, because we're talking about chronic disease is a behavior-driven
Absolutely.
disease. So let's look at the root of the problem. How do you change behavior? Biofeedback.
Right?
Biofeedback is provided by measuring. That's what biofeedback is measuring.
Absolutely.
And being able to see your data.
So most
The
people,
quantified self movement you've probably heard about.
the adoption rate of technology in America is tremendous. The amount of smartphones, obviously, that have been adopted in the last 5 years, and what we're looking at for the next 3 years is tremendous. So therefore, taking a piece of technology that you're putting into an environment, technologically savviness of people in general, and then empowering them on the health side of their lifestyle is going to change the way the life cycle in this country works, or globally.
Well, it's not just that. In fact, our adoption of smartphones is not as great as many other countries.
No,
Korea,
it's
South Korea,
not.
and
No, no,
India,
and
are
I'm
far
not
greater.
saying
So the
that.
opportunity is even larger
on a global
globally.
scale. It
Yeah.
very much is, but America happens to be a country that has one of the highest rates of obesity, has one of the highest rates of
Yes, you're right, you're
and
right.
so therefore
You're right, from that
from that
standpoint.
perspective, from a health. But listen, what did the study that came out the other day says that the American health system is at number 37 on a
Yeah,
global scale.
we're low,
Like,
yeah.
we don't like to be that low on the
No,
scale,
but-
right? So we got to do something to change it.
That's
so the
right.
adoption of technology, if it's already there, it's an easy step. It's a good bridge.
Absolutely. And listen, let's just go back 10
Okay.
years. Okay, let's go back 10 years. And you know what has the digital kind of revolution done? We now, the way we text, the way we email, the way we communicate, listen to books, the way we listen to music, everything, the way we drive our cars, everything's been changed because of mobile technology. Okay. It has not yet impacted the healthcare space.
No,
like
it has
should.
not.
And
No,
it is going
but then
to.
this, you and I had this discussion prior to getting on camera. This conference is 4 years old, and look at the tremendous growth that
It
it's
is.
had in the last 4 years.
Absolutely.
And you look at all of this stuff over here on this floor, and this is twice, 3 times the size as it was last year, and you're like, wow. There's a lot of attention in the mHealth space.
But until you take this, and then one of the issues that we came across with all this here, right? built this model and we were looking for software solutions.
Okay.
Could not find one.
Okay.
Because the problem is that you have engineers and technology folks coming into the game trying to find a solution to a problem that they don't understand.
So we had this conversation yesterday on a panel with Verizon and Orange where we talked about the idea that we as the technology community have been we've been asked to come over to the mHealth side of things and create technology, which we're good at because we mobilize data and we move it. And we're talking about siloed bits of data, so we understand that. Well, we're not physicians, so we don't.
Or behavioral scientists.
No, so we can only do what we know best, which is to create technology.
Which is why we need model systems to model it out and how the technology should be integrated.
How do we get more? How do we get more physicians like yourself involved in the process?
Show them that they can make money other than ways of treating disease.
Okay.
You can show them that you can build models that, Tom Martin from mHealth was just asking me across the way. And he's like, what is the paradigm? So last year I thought there was a real challenge to start getting physicians engaged. Now I think the challenge is showing outcomes, that you can do it. And then the next challenge is showing profitability, that you can actually have a retail model, which we're getting close to actually. We're getting close to profitability right now. We're not there yet, but we're getting very close. And the
if you're not pharma, medicine generally hasn't been a profitable model to begin with.
In general, well, it depends. If you're the doctor, it has been, right? Because you're able to bill.
But that's got to change.
That's got to change. Well, it's not that you want doctors to be able to make a living, right?
You want them to make a living, but you need to. The healthcare system in this country needs to change.
The healthcare
money has to move from one place to another because it's.
The incentives are perverse right now.
Okay.
The incentives are to do more, right? Not to do better. We need to not be doing more, we need to do better.
Okay.
And listen, we are doing some amazing things. I mean, you can have the best laparoscopes to take out tumors, the best chemotherapy to treat cancer. You have all that, and you should have that. But we need to really also focus on taking the diabetic, taking the hypertensive, and helping them prevent the stroke and the heart attack, and doing things like what we're just talking about, improving their cardiorespiratory fitness, decreasing their visceral fat. These are things that are going to reduce those rates. And also it puts them in control. So now they're in control of their health. It goes from a doctor-centric model to a patient-centric model, and that is what mobile health technology is doing.
What does that economic life cycle look like? How many years is it going to take before we see, if this adoption was widespread today and you were hitting a particular sense of critical mass, what's the life cycle? How long is it going to take to make that change where we're seeing an economic impact?
Oh, it's going to be I think our own model, we're very close to profitability. I think we'll be...
Not necessarily profitability of the company, just a switch in model.
I think with healthcare reform, it's going to come on fast.
Okay.
Because the incentives are already being taken away. If you look at it, we're going to a global kind of, I shouldn't say global, a countrywide kind of capitated system where ACO models, where you're going to get reimbursed per patient, despite what it's not going to be about more. It's going to be about, here's what you have. You get a piece of the pie. Regardless, this is the piece, this is how big it is, okay? So you're gonna have to figure out how to make that last. And the only way you're gonna make that last is by getting that model, the patient, to take control. The other thing I gotta say is I think that the EMR systems we have been all built wrong. I mean, they're built for the administrative closed system to build.
It is.
And they're not patient engagement platforms.
No.
So what we did with RevUp is really say we need a digital health companion. So we built social networking. I encourage you to go by our booth and take a look at the prototype. It's real patient data. Click on things. It'll take you to your genetic information, show you, eating disinhibition type traits. It'll take you to your steps and your fitness page. It'll take you to your lab page. It'll take you to all these different things. And we build in social network. We got links to Facebook. I mean, that is what's going to change medicine. It's that digital health companion which has been built to deliver outcomes. And that's why we didn't build it in a vacuum, right? We didn't build the software before I opened the business model. We built the software after I understood the delivery, and that's the problem. We're putting the cart before the horse. You need to actually be able to run the processes, then step back and say, okay, how can we take this and scale it, right? So economically, I think it's already happening. It's going to happen 2014. We're going to this ACO model. We're going to have to be more cost conscious. We're going away from fee for service. So I think you're going to see a rapid shift in the next 2 to 3 years, where people are now forced to say, wait, I need to think about innovative ways in which I can deliver this technology. And I think we're on the cusp of that.
Samir, I wish we had more innovators like you on the floor and running around. I think that the globe will be a better place at a faster rate.
Thank you. It's been a
Thank
pleasure
you.
talking to you.
Thank you very much. I appreciate that. I hope I get a chance for an update again in the future.
Absolutely.
I've been speaking with Samir Damani of MD Revolution here at the mHealth Summit in Washington, D.C. for 2012, and I'm Tony Sklar with bnetTV.